Blood pressure, hypertension, defined by the National Institute for Health and Clinical Excellence as a blood pressure that exceeds anything of a systolic reading of 120 over a diastolic reading of 80. 120 over 80 to 140 over 90 is pre-hypertension. 140 over 90 to 160 over 100 is mild. 160 to 180 over 100 to 110 is severe. And anything that exceeds either 180 or over 200 systolic, depending on what reference you read, is referred to as hypertensive crisis. Now, blood pressure essentially is the force of the blood exerted on the blood vessels. This is calculated by calculating the cardiac output multiplied by the peripheral vascular resistance. And your cardiac output essentially is your heart rate multiplied by time the stroke volume. Now, in average healthy individual, your blood pressure should be 120 over 80 systolic over diastolic. In terms of diagnosing blood pressure, there are a number of ways to do this. Generally speaking, we will take 3 readings all independently, and we will take the average of the lowest 2 readings, calculating that average and then using it against the criteria I mentioned a moment earlier. Other ways to do this is by means of performing what we refer to as an ambulatory blood pressure monitoring, which is a 24-hour blood pressure cuff attached to you, and the computer will automatically take readings at regular intervals. This is connected to a computer, and an average is calculated, but the margins change a little, such that if the patient is 80 years of age or under, and the diagnosis, instead of being 140 over 90 to diagnose mild hypertension, will be lowered to 135 over 85. If the patient is over 80, then that is changed yet again to 145 over 85, and the reason for the over 80s is because we accommodate for the loss of blood vessel or soft tissue compliance, i.e. the vasculature may have undergone some form of mineralization, usually calcification, therefore making them a little bit stiffer, reduced compliance, and therefore leading to a higher reading, hence a slightly higher threshold. In terms of symptoms, blood pressure, hypertension, there are 2 types. There's the primary and secondary. 95% of cases are primary, i.e. they have no underlying cause. The 5% that remain are generally referred to as secondary, and they may well have a secondary cause, underlying cause of various types. Symptoms wise, like I say, it's a silent killer because it has no symptoms for the most part of it, although some references do refer to symptoms including the likes of feeling very, very warm or a headache, particularly in the mornings when the patient awakens. In terms of complications, this is important, and the reason why we need to manage it. You can end up the high vasculature, the high blood pressure in the smaller vessels, i.e. those in the eyes and in the kidneys, may lead to hypertensive retinopathy and or hypertensive nephropathy respectively. Other significant incidents may include the likes of cardiovascular accidents, predisposed by particularly those patients at risk of VTE, venous thromboembolic events. These may include stroke, be it hemorrhagic or ischemic in nature. Appreciating ischemic strokes are about 75 to 80% of the situation, and the remainder being hemorrhagic. MI is also a risk factor in the same situation. Management. So how do we manage blood pressure? There is a whole host of concepts we need to appreciate here. First line management refers to the patient's, and is dictated by the patient's age, ethnicity, and or the presence of diabetes. So first line management for a patient who is under 55 or diabetic, and we will put the patient on ACE inhibitors, the likes of ramipril being the most commonly used here in the UK, and they come in 1.25 milligrams titrated up to a daily max dose of 10 milligrams. If the patient is over 55 or of Afro-Caribbean descent, then these patients generally have a poorer response to renin. Therefore, what we'll do is we will use the likes of calcium channel blockers, or we will use, after which, that's the first line in this group, and then after that we will use your A2RBs, angiotensin II receptor antagonists or blockers. The second line is such that we will use what we used in the first line in the other group with the second. So for example, if the patient was under 55 and we put them on ACE inhibitors, but that was insufficient, we will now add to that your calcium channel blocker or your A2RB. Your calcium channel blockers, mostly amlodipine, and your A2RBs, usually candesartan or losartan here in the UK. So the point here is, if you were put on ACE initially, you'll be put on CCBs and A2RBs, or if you were put on CCBs or ARBs, then we'll add on to that your ACE inhibitors as the second line. The third line is where we actually add a different drug altogether, and here what we're going to add is your diuretics. In terms of diuretics, we'll generally use your thiazides first, so it's like bendroflumethiazide, thiazide 2.5 milligrams, after which we'll use your loop diuretics like furosemide, 40 milligrams usually in the community, but sometimes even 20 milligrams. And then after that we'll use the likes of potassium sparing diuretics. And the reason we go in that order is because the efficacy or the effectiveness of these diuretics actually reduces in that order. Finally, we'll use, if that still is still not managed, then we will add in an alternate diuretic, or we'll add in a beta blocker, the likes of bisoprolol or atenolol, but this has to be dictated because beta blockers can be cardioselective or non-cardioselective, so we have to appreciate the whole history and other conditions such as asthma. And or otherwise what we may add is an alpha blocker. Alpha blockers work to actually reduce the peripheral vascular resistance because your alpha-1 adrenal receptors found primarily in the smooth muscles, and what they do, they cause vasodilation. And alpha blockers, the most commonly used here in the UK, again, is your doxazosin 400 micrograms, generally in the context of benign prostatic hyperplasia, but here we can use it for the same reason of managing hypertension. Appreciate, just before I go, ACE inhibitors, the most common side effect is your dry cough, and the reason for the dry cough is because your ACE inhibitors also inhibit one of the enzymes that actually break down bradykinin. So because that enzyme is not working, there is a buildup of bradykinin and substance P, both of which are actually irritants to the respiratory tract and therefore lead to the dry cough. Appreciate also that ACE is actually produced in the lungs, and that's why we have the impact on the dry cough. 40% of cases will demonstrate a dry cough. We will advise the patient to bear with this for 4 to 6 weeks if they are still complaining of the dry cough. After that, it is that we will consider changing the ACE to an alternate drug. Angioedema is the other issue with the use of ACE inhibitors, and of course if you've got renal compromise, then we need to be mindful of the same when using ACE. Thank you for watching.